Welcome, everyone. My thesis title is Treatment-Related Cardiotoxicity in Pediatric Oncology. My first project title is Comparing the Diagnostic Tools Accuracy for Early Detection of Cardiac Failure in Pediatric Oncology. This will be a systematic review and meta-analysis. My name is Nóra Beke. I'm a PhD student, and my mission is that encourage the attitude that clinical practice and research are inseparable, and my vision is that cancer patients should live good life quality without any complication. Although the 5-year overall survival of children with cancer is 80%, we pay a heavy price for it because of the serious cardiotoxic side effect of the treatment. Cardiovascular diseases are the leading cause of late morbidity and mortality. Childhood cancer survivors have 5 to 15 increased risk for heart failure, and almost half of the patients have myocardial injury. Current guidelines suggest echocardiography for monitoring, but in many cases it does not detect early enough. Otherwise, we know several other screening modalities, for example, other imaging technique, blood biomarker, genetic variants, and microRNA. But so far, there is no study that compares their accuracy. Therefore, our study aim is to find out which is the most accurate screening tool in detection of cardiotoxicity, and if we succeed, we can make a recommendation for which tool should be used in order to minimize cardiotoxic side effects. It is a very important topic because early detection allows us immediate intervention so we can save lives. Our clinical question is, what is the most accurate prognostic tool for predicting therapy-related cardiotoxicity in childhood cancer patients? We use PFO framework. The population is children with cancer and childhood cancer survivors, and the prognostic factors are cardiac biomarkers, echo, genetic variants, microRNA, and the outcome will be the prediction accuracy of heart failure. We use R under the curve, receiver operating characteristics curve, odds ratio, adjusted odds ratio. Our hypothesis is that echocardiography is the most accurate prognostic tool in prediction of therapy-related cardiotoxicity in childhood cancer patients. Our study clinical implication is that with the most accurate tool, we could give better disease outcome for the patients, less unnecessary tests need to be performed, the clinicians could follow appropriate recommendation during the treatment, and in addition to all, it could be a good starting point for developing even more accurate tools. My search key contains 4 domains, and the hit numbers can be found on the top of the slide. After the systematic search, I had 5,000 articles, and at the end of the all selection phases, I have 73 eligible articles. Based on the type of the predictive factors, we divided the articles into 5 major groups: microRNA, echocardiography, serum biomarkers, genetic variants, and AI models. And the outcome of these factors prediction performance, which is measured by AUC, correlation, odds ratio, adjusted odds ratio, and mean difference. Currently, we have done with the AI models. In this forest plot, we have summarized some of the predictive factors, and in this case, they are investigated in a complex prediction model built by AI. We have plotted the time-independent performance of this following model. These include different clinical parameters, which can be found in details in the bottom of the slide. 2 of them also use blood biomarkers, 1 of them also use ECG parameters, and 1 of them also use genetic variants. We used R under the curve as a unit, which shows the quality of the prognostic ability of these factors. The AUC is a region under the receiver operating characteristics curve, which shows that as we change the underlying continuous variable, the sensitivity and specificity also change. The value can be varied between 0.5 and 1. 1 means the maximum sensitivity and specificity, and 0.5 represents the result of random guessing. We used 3 studies. The cases number indicate the cardiotoxic patients, the control number indicate the treated but not cardiotoxic patients. 2 of the study use match control, and 1 of them use randomly selected controls next to the cases. These are cohort studies. The heterogeneity arises from the composition of the population here cannot be interpreted. The heterogeneity here arises from the differences in the prediction models. We use the state-of-the-art values. The overall accuracy is 0.8, but we can see that ECG parameter with clinical parameter reach 0.89 AUC value, which is an exceptionally high value. This is our first preliminary result, and it suggests that clinical parameters alone are not enough. Additional examination are definitely needed, and even then we cannot reach outstandingly good performance. Mathematical significance cannot be interpreted in this case, and question arises, if complicated AI models reach such a performance, what kind of performance are the individual factors capable of? Our study main strength is we try to create order in a chaos caused by a non-uniform publication strategy of the article. This will be a complex and comprehensive analysis of most of the predictive factors we have known so far. The limitations are incomplete data provision and the diversity of the definition and variables. That's why, in many cases, we cannot pull the results. Currently, I'm in the risk of bias phase. And my second project is investigating the side effects of tyrosine kinase inhibitors in pediatric cancer patients. This will be a systematic review and meta-analysis. One of the most promising groups in targeted therapy are tyrosine kinase inhibitor. These drugs work by blocking tyrosine kinase enzymes, so they affect gene transcription and DNA synthesis. The patients often receive them for years. That's why very important to know what their long-term side effect profile. The major groups of side effects, what they can cause, are cardiotoxicity, hepatotoxicity, endocrinopathies, and growth retardation. But so far, there is no comprehensive study about these effects. We plan to use 3, 5, and 10 years follow-up period, and therefore our study aim is to provide evidence of what side effects expected in the long term. Our clinical question is, what are the long-term side effects of tyrosine kinase inhibitors in pediatric oncology patients? We use PICO framework. The population is pediatric cancer patients. The intervention group is chemotherapy with tyrosine kinase inhibitor. The comparison group is chemotherapy without tyrosine kinase inhibitor, and the outcome will be the side effects. Our hypothesis is that tyrosine kinase inhibitor during the chemotherapy does not increase the risk for hepatotoxicity, cardiotoxicity, endocrinopathies in pediatric cancer patients. Our study clinical implication is give better disease outcome for the patients, provide evidence regarding its long-term effects, and clinicians could make preventive intervention in time. My preliminary research case contains 3 domains. The hit numbers can be found at the bottom of the slide. And since my vision is that pediatric cancer patients should live high-quality life without any complication, I would like to support this with my 2 studies. And I would like to end my presentation with the 19th century writer Ralph Waldo Emerson, all is a riddle, and Cato riddle is another riddle. Thank you for your attention.
Congratulations for the nice presentation. I would like to ask, what is the current practice of the screening of the cardiotoxicity in cancer patients?
We use echo for screening. Other screening modalities are not widespread currently in Hungary.
Any additional comments? Based on the literature and your knowledge, do you think in the very close future, which in 2 or 3 years, AI model can be help for the patients or the clinicians?
I think yes, and I think microRNA could be better than echo, and I think in a part of the AI model. So microRNA and AI model will be the future, I think.
We'll see. Any other? Yes.
Thank you for your presentation. This is right here. And this is referring to your first project. I have a question regarding the cardiotoxicity. Do you think that different cancer types will have an effect on the cardiotoxicity?
This was our plan at the beginning of the study, that we investigated the cancer type effect of cardiotoxicity, but most of the articles don't mention these details, so we don't know yet.